Hello, my name is Dr. Amgad Makaryus, and I'm a professor of cardiology at the Donald and Barbara Zucker School of Medicine and the Northwell Cardiovascular Institute here in New York, USA. I'm pleased to present to you today an article that we recently published in the journal Reviews in Cardiovascular Medicine, titled Traditional and Virtual Cardiac Rehabilitation: Understanding the Changing Landscape of Cardiac Rehabilitation and the Implications on Patient Outcomes. So my colleagues, Srinivula and Adrian Chen, and myself present this article because cardiac rehabilitation is a class 1 recommendation after myocardial infarction, coronary artery bypass surgery, PCI, valve surgery, transplant, peripheral arterial disease, and heart failure with reduced ejection fraction. All of these are class 1 indications for the use of cardiac rehabilitation. Cardiac rehab has been shown to lower mortality and readmissions, boost fitness, control risk factors, and improve the quality of life. Yet, despite all of these benefits, participation is still under 30% in many settings. When it comes to cardiac rehabilitation, what has been found is that the personalized assessment, combined aerobic resistance training, nutrition, risk factor management, and psychosocial support have been very helpful in a lot of these patients and have been pointed to as the factors showing improvement in these patients that undergo cardiac rehabilitation. Now, the progress with cardiac rehabilitation is usually tracked by the 6-minute walk test, assessing metabolic equivalence, as well as other factors of daily quality of life. And safety with respect to monitored cardiac rehabilitation is also found to be excellent. So as we mentioned, who benefits from cardiac rehabilitation? So first, we have patients with coronary disease or those who suffer a myocardial infarction and undergo revascularization. What we have found is that cardiac rehab can actually lower recurrent death and readmissions in these patients. And aside from that, it also improves mood for patients in terms of quality of life. With peripheral arterial disease, a supervised home walking program markedly improves patient function, and it is often better than actual interventions when it comes to peripheral arterial disease for improving walking time. In patients with heart failure with reduced ejection fraction, we find that these patients have better fitness, better ability to function, and there's also a mortality impact. But that, of course, depends on the adherence to cardiac rehabilitation. In patients with valvular heart surgeries or those even who undergo heart transplant, there's emerging evidence that there's fewer deaths and readmissions in these patients. And finally, the question of prevention. With cardiac rehab, it's been shown that improvements or use of cardiac rehab improves glycemic control, blood pressure, body composition is improved, weight loss can be realized, and all of these metabolic benefits go a long way in terms of decreasing cardiovascular death. Now, what we found in our review of the literature is that there is great underutilization of cardiac rehab. And because of that, we looked for some of the things that can actually lead to this or can actually be ameliorated to improve the use of cardiac rehab. And one of the biggest findings was the fact that there are actually a lot of cardiac rehabilitation deserts out there where patients don't have access, or there are not enough spots for patients to be able to use the benefits of cardiac rehabilitation. Other issues include transportation, caregivers who can help, low income, education, and finally, one of the biggest issues is under-referral, especially we found for women and for patients of low socioeconomic status and underrepresented groups. Now, some of the effective solutions would be automatic referrals. A lot of hospitals and a lot of physician practices now are undertaking the process of automatic referrals for anybody who would qualify for cardiac rehabilitation. Secondly, highlighting strong clinician endorsement of cardiac rehab for the class 1 indicated patients. Scheduling these patients near discharge. Have it as part of your discharge checklist to make sure that patients get this. And then finally, motivating patients and having their peers spread the word about the use and importance of cardiac rehabilitation. Another major possibility to fix the issue is virtual cardiac rehab. So virtual cardiac rehab, there's data out there as well, and this uses video, it uses wearables to track heart rate and other parameters, and it uses applications where the patient is able to do this in the comfort of their home while still undergoing the supervision and remote monitoring that a traditional cardiac rehab program would do. And generally, this actually matches the center-based cardiac rehab for exercise capacity, blood pressure, body composition. So studies have shown that there is just as much benefit, if not equal benefit, to virtual cardiac rehab compared to the traditional cardiac rehab. And usually most of these patients may require slightly more sessions with the virtual cardiac rehab just to get the hang and get into the cycle of the cardiac rehab, but you still have very good outcomes regarding virtual cardiac rehab. And then finally, there are some people that are trying out hybrid models, some live sessions, some virtual sessions that will review and reiterate some of the things done in the live sessions. So these hybrid models also are very useful and helpful for patients and might even enhance the quality of life. So what is the takeaway for all of us in the cardiology field? And the importance is, there are options out there for making sure that our patients who are indicated to receive cardiac rehabilitation actually receive it. And whether you choose a center-based approach, a virtual approach, or a hybrid approach, all of these should be tailored for the convenience of the patient to allow them to undergo this useful and proven beneficial technique for supporting patients. So what's on the horizon? What's next? So there are large trials that are currently undergoing, for example, the Sweetheart trial. And this trial will hopefully clarify further virtual cardiac rehab's long-term outcomes and participation effects. More research is definitely needed on this area in terms of quality of life metrics and expanding further indications aside from the class 1 recommendations that we presently have. For example, patients with atrial fibrillation, adult congenital heart disease. So taking all these things together, it's important that we highlight the importance of cardiac rehabilitation for our patients in daily practice to make sure that the patients that require it actually undergo cardiac rehab as they need. And by doing that, we can bring this important proven technique to all patients that require it. I thank you for your attention.